Okay, so we resume our lecture. Over here we have the levels of testosterone at different periods of life. So when you were a male fetus inside your mother's womb, when we measure plasma testosterone level, or we took your blood and measured your plasma testosterone level, we saw that between 3 months, or by 3 months, testosterone level was high in a male fetus inside the mother's womb, and the level declined to the 9 months of delivery. Then after the 9 months of delivery, the first 6 months the level rose again, but not so substantial. Then the level declined to puberty. During the pubertal period, that's from age 15 going, or from age 14, 12, 14 going, the level shoots up until age 15, 16, 17, remains stable till the man is 60 years old. So if you are even 60 years old, even here is 70 years. So a man, testosterone level will still be high. That's why men are sexually active even at old age. Because this dash line is sperm production. Meaning that when a man is even 70 years old, he will still produce sperm, but not as somebody who is 30 years, 40 years old. When a man is 80 years or even 100 years, he will still be producing sperm, but his fertility will be decreasing after 70 years. So that's why a 70-year-old man can easily marry a 20-year-old lady, and they will give birth and become happy family. I've already explained this. So we can see 7 months in the womb, the testis is not descended. Then at birth, the testis fully descends into the scrotum. You can see the gubernaculum attaching to the scrotal floor. We've seen this image already. What is the blood testis barrier? Let's go to the image. Okay, so this is the blood testis barrier. This barrier. There should not be any association between the sperms or the semen and our blood, or the human blood, because blood contains antibodies, cytotoxic T cells, and the rest. And the testis is foreign, because until testis is produced, the body does not know that testis belongs to it. Sperms belongs to it. So until sperms are produced, when sperms are produced, the body sees it as foreign. So the body will raise antibodies and T cells to fight against the sperm. So there should be a tight barrier produced by the sustentacular or Sertoli cells to prevent the human blood from coming into contact with the sperm, or else it will kill all the sperms. So when there is an infection at the area of the blood testis barrier, then we will have testicular inflammation and the rest, and that one will lead to infertility and even testicular cancer. So there shouldn't be any infection here. If there is any infection, it will compromise the barrier so that blood can have an association or contact with the sperm and destroy them. So that is the essence of the blood testis barrier. So let's go and see the blood testis barrier in clarity. So the blood testis barrier is a mechanical barrier that separates blood from the seminiferous tubules of the testis. It is formed by tight junctions between the adjacent sertoli cells near the basal membrane of the seminiferous tubule. The blood-testis barrier is formed by tight junctions between subtesticular cells, as explained earlier on, separating sperm from the immune system. And this prevents antibodies and other large molecules in the blood from getting to the germ cells. That's the proteins, polysaccharides, and cytotoxic substances do not come to contact with the germ cells, or else they will destroy the germ cells. And the germ cells are those spermatogenic cells, or cells that produce the sperm. So if they come into contact with blood, they will be destroyed. Germ cells are immunologically different from the body cells and would be attacked by the immune system or the antibodies and the cytotoxic lymphocytes, the cytokines in the blood. Substances permitted by blood-testis barrier. So the blood-testis barrier is accommodative to some substances, and these substances are nutritive substances essential for spermatogenic cells. Hormones necessary for spermatogenesis, like the FSH, LH, growth hormone, and the rest. Water can pass through the blood-testis barrier. So in an exercise, I may ask you which components or which substances can pass through the blood-testis barrier. You have to know the nutritive substances like carbohydrate and the rest, hormones and FSH, LH and the rest, and water. Damage of the blood-testis barrier. When the blood-testis barrier is commonly damaged by trauma or viral infections like mumps, whenever the blood-testis barrier is damaged, the sperms enter the blood. The immune system of the body is activated, resulting in the production of autoantibodies. Autoantibodies are antibodies produced by the same person. Auto meaning self. Autoantibodies. Autoantibodies, also called self-antibodies. But antibodies produced by the same person or the same body. Okay. The immune system of the body is activated, resulting in the production of autoantibodies against the sperms. The antibodies destroy the germ cells, leading to consequent sterility. Functions of the testis. It has a gametogenic function, that it produces sperms. It has an endocrine function, that is, it produces testosterone or hormones. The gametogenic functions of the testis is called spermatogenesis. Spermatogenesis is the process by which the male gametes, called spermatozoa, are formed from the primitive spermatogenic cells, that's the spermatogonia A and B in the testis. It takes 74 days for the formation of sperm from a primitive germ cell. So sperm formation takes 74 days. Spermatogenesis. What are the stages? Stage 1, proliferation or mitosis, and it is under the influence of follicle-stimulating hormone and growth hormone. Stage of growth, primary spermatocytes grow into a large cell under the auspices or by the help of growth hormone and testosterone. Stage of maturation, that is growth hormone and testosterone control it. Stage of transformation, that is spermiation, is the release of mature spermatozoa from the sertoli cells into the lumen of the seminiferous tubules, and it is influenced by testosterone and estrogen. So let's see, spermiogenesis is the process by which spermates become matured spermatozoa. So this is sperm maturation, is called spermiogenesis. And the changes taking place during spermiogenesis include condensation of the nuclear material formation of acrosome, mitochondrial spiral filament and tail structures, removal of extraneous or extra volume of non-essential cytoplasm. So let's see the stages of maturation. This is how a sperm matures. Okay, so we can see here, 1. Appearance of acrosomal vesicle and flagellum in spermatozoa. So this is the acrosome that appears in the basal body that produces which flagellum is attached to. Growth of acrosome and flagellum. So the acrosome continues to grow, the flagellum continues to elongate. Shedding of excess cytoplasm. So cytoplasm, too much of cytoplasm, too much of everything is bad. So cytoplasm needs to be shed or removed or destroyed, most of them, because it doesn't need all this big quantity of cytoplasm. Because when the sperm is swimming to the egg and there's too much of cytoplasm, it will be very difficult for it to swim because it will be very heavy. So it has to shed some of them. Then the acrosome fully grows. We have the meat piece consisting of mitochondria. And what's the essence of mitochondria in the meat piece of the sperm? Mitochondria is noted for energy production. So it has a lot of mitochondria so that it can be able to get enough energy to swim from the vagina to the fallopian tube, the ampler region of the fallopian tube, to go and fertilize the female ovum. So we can see a lot of mitochondria when we have the tail, the full tail, mature sperm. So it started from here, a cell shed its cytoplasm, elongated tail or flagellum, and became this matured sperm. And the acrosome layer it has hydrolytic substances that will digest the egg, the boundaries of the egg, so that the sperm can enter inside it and fertilize it. Factors affecting spermatogenesis. The factors affecting spermatogenesis are Sertoli cells, hormones, and other factors. So let's see. Hormones that affect spermatogenesis are follicle stimulating hormone, testosterone, estrogen, luteinizing hormone, growth hormone, inhibin, activin. So let's see, this is the hypothalamus pituitary gonadal axis. Hypothalamus pituitary gonadal axis. Pituitary gland, gonad means that the testis. Axis. Let's see it. So this is what happens. So the hypothalamus is here, the anterior pituitary is here. We have anterior pituitary here, posterior pituitary. The anterior pituitary is called the posterior pituitary is called neurohypophysis, and the anterior pituitary is called adenohypophysis and neurohypophysis. Okay, so let's see, the adenohypophysis is responsible for production of most of the hormones. So let's see. So we have the fertility hormones, we have the FSH, LH, and growth hormone produced by the anterior pituitary. So FSH causes Sertoli cells to produce or activates Sertoli cells or tentacular cells to produce inhibin, activin, and estrogen. Whereas LH stimulates Leydig cells to produce testosterone, and testosterone influences spermatogenesis. Estrogen over here also influences spermatogenesis. Growth hormone goes directly to influence spermatogenesis. Inhibin goes back to inhibit gonadotropic releasing hormone and follicle stimulating hormone, preventing it from producing more estrogen to affect, or activin to affect spermatogenesis. Whereas activin will activate FSH to stimulate Sertoli cells to produce spermatogenesis. So these are the hormones. This is the path. Let's go. Hormones secreted by testes. Testes secretes male sex hormones, which are collectively called the androgens. The androgens secreted by testes are testosterone, which is the most abundant. We also have dihydrotestosterone, which is more active than the rest. We also have androstenedione. Functions of testosterone in adult life. The testosterone increases the size of penis, scrotum, and the testes after puberty. It affects muscular growth. It affects bone growth. It affects shoulder and pelvic bones. It has effect in skin production. It has effect in hair distribution. It influences the voice of a male child. It has influence on basal metabolic rate, electrolyte and water balance. It also influences erythropoiesis or blood production. So these are the hormones. You can go through this picture, and this is spermatogenesis. I've already explained spermatogenesis. Okay, so spermatogenesis starts by premortal germ cells form in the yolk sac of the embryo. They colonize the gonadal ridges and become spermatogonia. So you can see spermatogonia. They are the primordial germ cells. In spermatogonia A, there will be mitosis and to produce B, and the A will remain. Puberty brings on spermatogenesis. Spermatogonia lie along the periphery of the seminiferous tubules and divide by mitosis. So it is lying at the periphery, the basal membrane, and divide by mitosis to produce type A, type B spermatogonium, and type A spermatogonium. So let's see primordial germ cells. Let's see primordial germ cells. So this is the primordial germ cells. This is the nucleus of the primordial germ cells staging. It will now undergo mitosis to produce two daughter cells, which are of the same shape, the same size, the same genetic component. This one become type A spermatogonium, A spermatogonium 2 gonium, and type B spermatogonium. So the type A and the type B spermatogonium. Now the type B spermatogonium will go and mature to become primary spermatogonium, as primary spermatocyte, and divide to become secondary spermatocyte, which will undergo mitosis to produce four daughter cells. So we see that in the diagram. So we can see type A, the primordial germ cell will become type A and type B. Type B spermatogonium will go and undergo mitosis, undergo meiosis and divide to two daughter cells. Each daughter cell will divide to four daughter cells, lead to the production of sperm. Okay, so let's see. So I've already explained this. The tentacular cells protect it from body's immune system. Primary spermatozoa undergo meiosis, give rise to equal size, haploid, genetically unique secondary spermatozoa. So I've explained this already. Okay, so let's see. Once the primary spermatocyte undergoes meiosis, it becomes genetically different and needs to be protected from the immune system. The primary spermatocyte moves toward the lumen of the seminiferous tubule, and a new tight junction between the testicular cells forms behind it, now protected by blood-testis barrier closing behind it. Okay, so I've explained this diagram also. So, spermatozoon. So the spermatozoon, let's see the parts of the spermatozoon. We have the head, the acrosome, which produces hydrolytic substances that will digest the egg, so that the DNA, because the DNA is here, the nucleus is here, can fuse the DNA of the female or of the egg to produce a zygote. We have the basal body here, which the flagellum attached to. We have mitochondria to produce energy for the sperm to be able to stream from the vagina to the fallopian tube, the amplar region of the fallopian tube, where fertilization occurs. This is the midpiece of the tail. This is the azoneme, is the first part of the flagellum. Then the principal piece is where the flagellum is mostly concentrated, and the end piece. So you can see that in this description over here. What is the semen? Semen is also called seminal fluid. It is the fluid expelled during orgasm. 2 to 5 ml of fluid expelled during ejaculation contains 60% seminal vesicle fluid, 30% of prostatic fluid, and 10% sperm and spermatic duct secretions. Normal sperm count in a male, a healthy male or a fertile male, is 50 to 120 million per male. Lower than 20 to 25. Now they've even brought it to lower than 15 million. That is the cause of infertility. The prostate gland produces a thin milky white fluid that contains calcium, citrate, and phosphate ions. It also contains a clotting enzyme, protein hydrolyzing enzyme called serine protease, or prostate-specific antigen. So the prostate gland produces protein hydrolyzing enzyme called serine protease, or prostate-specific antigen. Hey, the sperm is rich, the semen is rich, and it has what? Calcium, citrate, phosphate ions. It also has the seminal vesicles contribute viscous yellowish fluid, which contains fructose and other carbohydrates, citrate, prostaglandins, and protein called proseminoglycan. Hey, the semen is sweet. Hey, the semen has a lot of nutrients. It has a lot of minerals also, all to aid the sperm to be able to stream to the female fallopian tube, amplar region, for fertilization to take place. The semen is sticky due to clotting enzyme from prostate, which activates proseminoglycan and converts it to a sticky fibrin-like protein, seminoglycan. It entangles the sperm, sticks to the inner wall of the vagina and cervix. So the stickiness of the semen ensures that the semen does not drain back into the vagina, and this promotes uptake of sperm-laden clots of semen into the uterus. But after 20 to 30 minutes after ejaculation, serine protease from prostatic fluid or prostate fluid breaks down seminoglycan and liquefies the semen. Sperm becomes active. So when the sperm is liquefied due to the breakdown of seminoglycan, then the sperm becomes active with linear progression. Prostaglandins thin the mucus of the cervix and stimulates. The cervix of a woman has cervical mucus plug. Cervical mucus plug. So the cervix of the woman, this is the cervix, this is the vagina. Okay, this is the womb, this is the fallopian tube, this is the fundus. Okay, so the cervix is here. There's a mucus called cervical mucus plug. Cervical mucus plug. This cervical mucus plug prevents infection and prevents things entering the cervix. When they enter the cervix, they will enter infection, and other things will enter the uterus and cause the woman to have infection, which is not good. So God, in his own wisdom, put a mucus plug inside the cervix, the hole, so that nothing can enter inside. So what happens over here is that prostaglandin in the sperm will thin the mucus of the cervix and stimulate peristaltic waves in uterus and uteri. So prostaglandin will cause this thick. The cervical mucus plug is very thick, but the prostaglandin in the sperm or in the semen will cause it to be thin, so that the sperm can easily flow, move through it, swim through it, and go to the fallopian tube at the ampulla region to go and fertilize the egg. Two requirements for sperm motility are elevated pH and an energy source. Prostatic fluid buffers vaginal acidity from 0.5 to 7.5. So the prostate fluid also increases the pH of the vaginal fluid, because the vagina is acidic. So if it's acidic, when the sperm gets to the vagina, it will die. The acid will kill it. So the fluid in the prostate, or prostatic fluid inside the semen, will increase the pH so that it will come to a neutral. The pH will become neutral, so that the sperm will not be killed by the acidity. Seminal vesicles produce fructose and other sugars to the mitochondria to release energy for the sperm fluid to swim well. Testes and associated structures. Rectus testis, I've explained it. Testicular artery, pampiniform plexus, testicular nerve, I've explained all of them in the anatomy class. So this is the epididymis. Look at the various parts. The caput is the head, the corpus is the body, and the cauda is, anytime you hear cauda in anatomy or medicine, the cauda is tail, corpus is body, caput is head. Spermatic duct, I've explained this already, so you can remember this structure. You can also remember we have three types of ureteras. We have the prostatic urethra, membranous urethra, spongy urethra, or pineal urethra. So the urethra, we have the prostatic one here, the pineal. Pineal means that it's prostatic urethra, membranous, it runs through the membrane, perineal membrane. This is the perineal membrane, so it runs through, so it's called membranous urethra. And the pineal urethra runs through the corpus spongiosum. There are three sets of glands in the male reproductive system. The seminal vesicles, that's a pair of glands. Let's see the seminal vesicles. So these are the seminal vesicles. 1, 2, 1, 2. So let's see what they do. So there are three sets of glands in the male reproductive system. The seminal vesicles, the pair of glands posterior to the bladder, empties into the ejaculatory duct, forms 60% of the semen. So The seminal vesicles are here, 1 and 2. Empty into the ejaculatory duct. This is the ejaculatory duct. The ejaculatory duct now goes and joins the prostatic urethra. We have the prostate gland, which surrounds the urethra and ejaculatory duct, just inferior to the bladder. It empties about 20 pores in the prostatic urethra. Thin milky secretion forms 30% of semen. So we can see the prostate gland. This is just a revision. Prostate gland, and this is the ejaculatory duct and the prostatic urethra. It houses them. We also have the bulbourethra or Cowper's gland. Let's see it. The Cowper's gland, this small pea-shaped gland, is called Cowper's gland or bulbourethra gland. There are two. It's a pair. One is here, one is here. What does it do? So they are near the bulb of the penis. So let's see. This is the bulb of the penis, and this is the shaft. The bulb is buried inside the perineum. During sexual arousal, they produce a clear, slippery fluid that lubricates the head of the penis in preparation for intercourse. It also protects the sperm by neutralizing the acidity of the residual urine in the urethra. I explained this in the previous lecture, that the Cowper's gland produces fluid that lubricates the head. You know, before you ejaculate, there's some fluid that comes first. So you think that you have released sperm, but that's not sperm. That is just a fluid to lubricate the head of the penis, so it can be able to enter the woman well without any friction. And this fluid also, what it does is that it cleanses or neutralizes the acidity of the urine that you have been using, because you have been using your penis to urinate. So uric acid will be inside your urethra. So the secretions from the Cowper's gland is supposed to neutralize and make the urine, the residual urine in the urethra, non-acidic. These are some of the, let's look at some of the conditions of the prostate, diseases associated with the prostate gland. We have benign prostatic hyperplasia, BPH. That is non-cancerous enlargement of the prostate. When the prostate gland becomes big, but it is not cancerous, it's benign. This compresses the urethra, obstructs flow of urine, promotes bladder and kidney infections. You see, when the prostate is enlarged, it will compress the prostatic urethra. Urine cannot pass through. You know, the prostate is connected to the urinary bladder. This is the urinary bladder. So when the prostate is big, urine cannot pass through the prostatic urethra and enter the membranous urethra and the pineal urethra. So urine will now feed back, go back into the kidneys. An accumulation of urine in the kidney is what we call hydronephrosis. Hydronephrosis. So meaning that kidneys, water in the nephron, water accumulation in the nephron. Hydronephrosis. This accumulation of fluid, or if you know the urine will find difficult, the person will be urinating small, even at night. Instead of all the urine coming out of the bladder, the patient will be urinating small, and not plenty, because something is blocking the urine from coming out. This will lead to infections in the kidney and also infections in the bladder, in the urinary bladder. We can also look at prostate cancer. That's the second most common cancer in men after lung cancer. These tend to be near the periphery of the gland where they do not obstruct urine flow. So if somebody has prostate cancer, it doesn't necessarily need to obstruct urine flow. The person can be urinating because the cancer or the source, cancer lesions will be around the periphery, outside of the prostate, outside of the gland, the outermost part of the gland, so that it doesn't obstruct urine flow. So why is it dangerous? These tend to be near the periphery of the gland where they do not obstruct urine flow. They go unnoticed until they cause pain. When they metastasize, that is when the cancerous cells now invade the blood vessels, the lymph nodes and the rest, the lungs and other organs, they become so dangerous. Digital rectal examination is done when the doctor puts his index finger in the rectum to check for abnormalities in the anus, rectum, and prostate gland. The doctor here has to wear gloves and apply lubricant to his index finger before he can push the index finger into the anus to access or feel the prostate, the anus, and the rectum. So this is a way of detecting whether somebody has prostate cancer or not. But we can also diagnose prostate cancer by looking at the levels of serum protease, that is prostate-specific antigen, and acid phosphatase in the blood. So laboratory, when people come to you that they want to check whether they have prostate cancer, the only thing you can do for them is to do the scan to see whether the prostate is enlarged. Then you draw the blood to see whether there is elevated serum prostate or increased serum prostate. Serum prostate is the same as prostate-specific antigen in the blood. You can also check whether there are higher levels of acid phosphatase in the blood. But you don't go and do digital rectal examination because you are not licensed to do that. It's the medical doctor who is licensed to put his index finger in the anus and be moving it around to check whether there is any abnormality in the anus, rectum, or the prostate. Okay, so the penis serves to deposit semen in the vagina. I've explained the penis already. We have the foreskin, the circumcision, the sphincter, so you can go to the anatomy lecture. I've also explained that the penis has 4 erectile muscles. Here we say 3, but there are 4. We have double corpus spongiosum and 2 corpora cavernosa muscles. And the 3 cylinders of erectile tissue are spongy. They contain many blood vessels called lacuna. So you know what makes your penis erect is that it contains lacuna and trabeculae, which are filled during sexual activity, so that the penis will be hard. So the woman will see it and say, "Ah, what a hard penis," and she will be clapping for you, calling you da 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 da. Okay, puberty and climacterics. Reproductive system remains dormant for several years after birth. But during puberty, that is 10 to 12 years in most boys and 8 to 10 years in most girls, there's a surge of pituitary gonadotropins, which awakens the reproductive system with the onset of puberty. A surge of prostate-specific follicle-stimulating hormone, luteinizing hormone, growth hormone, and gonadotropic releasing hormone. There is a surge in them. Adolescence is the period from the onset of gonadotropin secretion and reproductive development until a person attains full adult height, whereas puberty is first few years of adolescence until the first menstrual period in girls or the first ejaculation of viable sperm in boys, typically around age 12 in girls and age 13 in boys. Meaning that when you are, before we can qualify you as being of a puberty age or pubertal age, you should have produced alive sperms that are alive. The sperms you'll be producing before puberty are dead sperms. They are not viable, they are dead. So you have to produce sperms that are active with linear progression. Endocrine control of puberty. So like I said, testes secrete substantial amounts of testosterone in first trimester. That's 3 months of fetal development in levels about as high as they are in mid-puberty. Then testes become dormant until puberty. From puberty through adulthood, reproductive function is regulated by hormonal links between hypothalamus, pituitary gland, and the gonads. As hypothalamus matures, it produces gonadotropin-releasing hormones. And I think I've explained this already. So let's go. So other hormones also, puberty leads to enlargement of secondary sexual organs, penis, testes, scrotum, ducts, glands. Testosterone stimulates a burst of generalized body growth, limbs elongate, muscle mass, and I've explained this already. Stimulates sperm production. Testosterone stimulates sperm production and libido. So if you have high testosterone, you have high ability to produce sperm, and your libido, your sexual drive is very high. Adulthood. Testosterone sustains the male reproductive tract, sperm production, libido. That is in adulthood, and in childhood to stimulate sperm production and libido at puberty. Inhibiting from testicular cells suppress FSH output from the pituitary, reducing sperm production without reducing LHF. So you saw this in the diagram. Let's see aging and sexual function. Decline in testosterone secretion, peaks secretion. Okay, so at age 20, there is high secretion of testosterone. But if you age to 80, you have 1/5 of testosterone secretion, meaning that decline in the normal activity of interstitial cells, that's testosterone and testicular cells, results when you age. So when you are 80 years, you don't assume that you will produce testosterone and produce sperms like somebody who is 20 years of age. The level of sperm production and testosterone level will be decreased as you age. But it's better than women who will not ovulate after menopause. Rise in FSH and LH secretion after age 50 produces male menopause or climacterics, andropause. Little or no effect because mood changes, hot flashes, and loosening of suffocation are not there. So it's not like women who will feel like they are being suffocated, they can't breathe, they have hot flashes and their mood changes, and they will say they will be changing, mood will be changed. Today they are angry, tomorrow they are happy. That is a woman. But it's not like that with men. It's not like that with men. So erectile dysfunction or impotence is the inability to produce or maintain an erection sufficient for intercourse, and this happens in 20% of men in 60 years to 50% of those in 80 years. So 20% of men in 60 years have erectile dysfunction, and they are not able to make the women become so happy, and the number of the men with this condition increases as they age unto 80 years.